Good afternoon, everyone. Welcome to our webinar today. This webinar is organized as part of the pre-scientific conference of the Teens Ethio Health Exhibition and Congress, which is going to be held in Addis from April 2 to 4 at Addis International Convention Center. And this webinar is particularly organized in partnership with Medical Research Lounge and Fenot Associates. So to introduce myself, my name is Addis. I am the founder and general manager of Medical Research Lounge and the scientific conference lead for the Ethio Health Exhibition and Congress. So today's webinar topic will be on getting to know health policy and evidence-informed decision-making. So this session is basically aimed to equip healthcare professionals, whether you are a researcher or not, with a clear foundational understanding of how evidence-informed health policies are developed, implemented, and evaluated within a complex healthcare system. So to achieve that, we have invited two speakers, actually collaborators. I would rather call them that because they're also organizing partners for the session and also the scientific conference. And these speakers are very well experienced in the field and they have a lot to share. And we are really glad to have them here today. So I know these are very well-known professionals and by most of you, but let me present a very brief summary of both speakers. So the first speaker is Professor Noel Girma. He is a pediatrician with more than 25 years of experience in clinical practice, research, and medical education, holding an MD from Jimma University, pediatric specialty training from Addis Ababa University, and a PhD in pediatrics and international nutrition from the University of Copenhagen. He's widely recognized for leadership in improving the management of acute malnutrition and for strengthening nutrition and health research capacity in Ethiopia, including as the founder and principal investigator of the Clinical and Nutrition Research Center, JUCAN, at Jimma University, which I believe most of you who work there know. So since July 2014, he has been serving as the director of the Ethiopian-based Fenot Harvard project, which supports primary healthcare system strengthening through evidence generation and use. So Professor Noel also serves on multiple national and international technical and advisory groups. He holds visiting and honorary academic appointments in Ethiopia, Denmark, and the United States. And he is also a member of several professional societies and has published extensively. And the second presenter is Professor Mrkuze Wolde. He is a policy and management specialist with over 20 years of experience as a researcher, educator, and policy advisor in public health and health policy and systems management. He has led several health policy and systems research projects focusing on community health systems, maternal and child health service quality and utilization, health equity, and quality of health services. He's well published, having more than 90 peer-reviewed publications. He is a health policy and systems senior advisor at the Ministry of Health, Ethiopia. Professor Mrkuze Wolde is also the deputy director for evidence to policy work stream of the Fenot project of Harvard T.H. Chan School of Public Health, which is based in Addis. He is also an adjunct health policy and systems professor at the University of Technology, Sydney, Australia. And he also holds adjunct professorship at a number of high-ranking universities in Ethiopia, including Bahar Dar, Walaita Sodo, and Jimma University. So this is a very brief summary of both professionals, but I know they haven't shared a lot of other appointments they have currently, including working in journals and other relevant research areas. So please please join me in welcoming both speakers. Thank you very much. We're so glad to have you here. So I'll hand the mic to Professor Mrkuze. Over to you.
Thank you, Dr. Tegist, for the generous introduction. So welcome everyone, and thank you for joining and being interested in the topic we will be covering today. So the first activity in this webinar will be for you to join this Mentimeter, which I have shared on the screen. You can scan the QR code or go to mentimeter.com and insert the code that you see on the screen. So all of you can do that. You can use your phone. Once you have joined, you can respond. You can give a brief response or you can select out of the alternatives for the following questions. Yeah, so we will be monitoring your response on the screen. So you will see you will not see who responded what, but you will see the response of people on the screen as we see. So this is the first question. I will give you 30 seconds to respond to this question. Yeah, yeah. Let me give you time to join. Yeah. Good. We have a good number of the participants joined. This is how your answer appears. Yeah, we have 44 participants, so we want many more to join. We have only 27 joined the Mentimeter. If you have any technical difficulty, just drop it in the chat box. Yeah, Dr. Tigist has also shared the link for you to easily join by clicking the link. You better respond on Mentimeter, not on the chat box. Yeah, so as you can see, many people have said primary health care. So when they hear health policies, that's what comes to mind. Guidance, direction. These are the most common responses you have provided in the group. But we also have a rule of conduct, guideline, public health, policy making, health, even MOH, Ministry of Health. Yeah. So thank you so much. We will move on to the next question. When I move the slides, you will see the next question, so you can give your answers. Let's move on to the next question. The next question, the second one, is which of the following is an example of a health policy? We would like to know which of these you consider as a health policy. So the bar graph will show how many of the persons in the webinar selected that response. Yeah, so many people are choosing national immunization program. We have seen one standard operating procedure of a laboratory test. Okay. For those of you who have joined late, you can scan the QR code that you see on the screen to join the mentimeter.com and respond to this question. Or you can directly go to the chat box and click the link and respond to the questions. We have 34 participants who have joined the Mentimeter test out of 52 participants. So we want all of you to join and share your thoughts about health policy. Okay, let's move on to the third question. This one says, which step comes first in the policy making process? So the earlier questions were about what a policy is, while this one is about the processes through which policies are developed or made. So those of you who have joined late, you can still scan the QR code or click the link in the chat box to join the Mentimeter test. As you can see, many participants have identified problem identification at the first step in the policymaking process, while policy formulation, implementation, evaluation are all the options which have been selected by some. Excellent. We are being joined by more participants into the Mentimeter. Good. Don't forget about this observation. We have many of the participants choosing problem identification as the first step. And we'll discuss what happens in real context. And this is the fourth question. What comes to your mind when you hear the word evidence? What does it mean for you? You can drop a phrase or a word. Information, research, tested, decision, data. All are interesting concepts, very much related to evidence. Yeah. And understandably, many of you have said research, data, information. But others have said pattern, knowledge, research-based evidence synthesis, research study, systematically collected data, all of which makes a lot of sense in relation to what evidence is. We have 25 of the 42 participants who have joined the Mentimeter responded to questions, so you can respond, all of you. So data is leading as we speak. Then we have information, research, knowledge. Yes. Good. We will have one more question. Excellent. This is how the word cloud looks like. Data, information, research, knowledge leads in the response. Let's move on to the last question for today, for opening our webinar. So it says, which of the following is most influenced by scientific evidence? So you have three alternatives: malaria treatment guidelines, operational guidelines to implement taxation of alcohol and tobacco, then eligibility criteria for enrollment in a health insurance scheme. A clinical guideline for malaria treatment is leading, but we have respondents joining to that, indicating to other alternatives too. Good. So thank you very much for your active participation in this response. We will come back to your responses later on while we do our presentation, our talks in turn. So I will stop sharing and I'll go to the slides. So in the meantime, if you have any questions as we do our presentations, you can put them in the chat box. I hope everyone can see my slides.
Yes.
Can you see my slides?
Yes.
Good. Yeah, so the first segment of our webinar today is on health policy making and analysis, which contributes to the overall theme, which says getting to know health policy and evidence-informed decision-making. The second half will be about evidence-informed decision-making, which will be done by Professor Tsunel. So in this half of the session, we will try to define what policies are, explain the different stages in policy making, and give you a little bit of flavor about policy models and frameworks in policy analysis, and do a bit of discussion about policy analysis. So it's good to first rationalize why we spend time talking about policy making, as researchers or clinicians or other practitioners. Why should we worry about policy making itself in the first place? So the first reason is the process of policy making is a lot more complex than we assume. So it's better to really give it due attention to really understand how it's done and how it affects population health status. After all of us intend to impact population health, which actually begins with crafting policies, and proper implementation of policies is really like a prerequisite to appropriate population health development. Another good reason we have to really take time and discuss about the policy making process is the process of policy making itself is very complex, and it rarely happens rationally and transparently as we usually assume. So it needs a deliberate effort to really understand what happens behind the scene in terms of crafting policies, implementing them, evaluating and analyzing policies. And those who make decisions are not always visible, and they are different from those who don't make decision or who do not involve in the policy making process. So understanding this complexity in health policy making would help a researcher, a practitioner, clinician, or public health practitioner to really understand and navigate the policy making process good enough while executing his or her responsibilities. So what is the purpose of health policy anyway? It is to help us make choices, and choices would always lead to consequences. For example, we make choices or we make decisions about technologies to develop and use in the health system. In health policy, we also make decisions about how to organize services, how to finance them, for whom to provide care for free, whom to exempt from payment, and so on. So all these are important undertakings in the health system that are highly impacted by decisions in the policy-making process. That's why we take time. In our opening Mentimeter exercise, I asked you to really give us a word or a phrase about your thoughts about health policy. And a policy analyst also, inquired civil servants about this. How do you define policy? And this is a quote she provided, in relation to that. Policy is rather like the elephant. So one of the participants said. He said, you recognize it when you see it, but it cannot be defined. So it is to say policy, this is a word that is used right and left, but not usually understood in its full meaning. We also asked you to give examples. As you said, policies give directions, they guide action. They are also made by institutions like the Ministry of Health that you have mentioned, and so on. These are all relevant to the policy-making process, but what is policy itself? What does it mean is the most important question we wanted to raise. And we have also asked you to give examples. We will come back to the examples later on. So this is the definition the policy analyst I cited earlier provided after talking to people about what policy is. She said policies are expressed in a whole series of practices, statements, regulations, and even laws, which are the result of decisions about how we will do things. So policies determine how we will do things in a future time. So we sit back and decide on how to behave and how to execute actions to reach to a particular goal. But remember, policies could be practices. Are they written? Not all practices are written. So even there are unwritten policies. So, a practice shouldn't be, it's not necessarily written, but it can still be policy. Why? Because it determines the behavior of people within a system or institution or organization. But it could be also formally written statement. It could even be a regulation, which has to be obeyed. And it could even be a law, which is attached to a penal code. So policies determine ways of doing things. They determine behavior, action within an organization and institution. So they could even be available within a household. Nobody chose the alternative of exercise routine. A personal exercise routine was not chosen. But for that person, it determines behavior. It determines how things are done for that particular person. So it is his or her policy. So we have policies even in households, in personal lives, in organizations, in systems and in institutions. Another group of policy analysts said policies are broad statements of goals, objectives, means, and the means that create the frameworks for activity. Meaning, in any policy, you need an objective to be attained, and you need also the framework or the strategies to execute action to reach to the objective. So policies could be explicitly written documents, implicit or unwritten documents. They could even be discretionary, meaning they are left to individuals to choose to follow them or not. And sometimes they are also regulated by law. They are statutory. The penal codes are attached to them. So policies determine behavior and they determine how things are carried out in an organization or in a particular setting. As, or not all policies are declared, as you can see in the image. So they could be implicit and unwritten. So in summary, health policies are courses of action or inaction. You might choose not to do anything about a particular health problem, for example, and that's your policy. So it could be a course of action or inaction, a decision not to do anything, that affects the set of institutions, organizations, services, and funding arrangements of a health system. So they determine course of action or they determine behavior within an organization or system. That's what policies are. So you might be active or lazy. You are making a choice, you are making a decision, and that's your policy. So going back to your choices in the Mentimeter, while majority of you said, policies are made like consecutively, and many of you chose problem identification as the first choice. It might not be the case in practice. Sometimes implementation might begin even the problem was appropriately examined. So although they are not sequentially done, we have some steps, some key steps that we take in the policy-making process. But let's remember the complexity. It is a complex dynamic process where a series of actions and inactions are observed, and a variety of groups with variety of interests are engaged within at different levels of the policy process. And it's not just about a particular decision made at a point in time in the in a health system or in an organization. It is a result of ongoing interaction among the institutions, interest groups, and ideas that are involved in that particular issue. So it might result in a paradigm shift, or it could simply be an incremental change within an organization or system. These are, the conventional issues that happen in the policy-making process. Problem identification, which usually is known as agenda setting, policy formulation and decision-making, then policy implementation and policy evaluation. But the sequence might not be always, from 1 to 4. Sometimes, as I mentioned earlier, implementation of actions to address a problem might start even before the problem was adequately understood, particularly in emergency situations, such as in the case of pandemics and epidemics and so on. We go for action before even we properly understand the problem. So while we don't count on the sequence, these are the main things that happen within the policy-making process. In problem identification and issue recognition, what we try to do is to identify the issue, set the goal, then identify alternative solutions for that particular issue, appraise the options. Then we go to writing the policy, which usually is done by technocrats, policy formulation. Then once policy is formulated, once written on paper, it is submitted to a decision-making body for approval. Then implementation follows. This is a very critical stage of the policy-making process, which is usually ignored or left to the final stage, but has to be thought of at the beginning, because implementation is the most important part even if you have the best policy, if you don't have the arrangements for proper implementation, then it will be a failure at the end of the day. Then evaluation is, of course, very important, and it will feed into the problem identification process, and the cycle continues. In the policy-making process, a very critical stage is the agenda setting stage. And you might think about, when do actions happen in the health system? Are all pressing problems in the society addressed by the health system or the government system? That might not be the case. Why does that happen? Although problem and policies or solutions happen to be present or felt, understood for a long time, the political willingness or the window of opportunity doesn't usually occur as quickly as we want it. So these are three streams. According to this policy analyst Kingdon, he proposed this multiple stream framework in 1984. He said, for action to happen in the health system, for a policy to be enacted and implemented properly, the problem has to be understood. Then the solution should be there, which is a policy, but the political environment should really allow it. So even if problem and solution exist together, the political window is important. So the streams should really meet all together, not just two of them. They should all meet together. It's only then that agenda setting, problem identification is much easier. And moving on to the different models which were crafted in an effort to understand the policy-making process. These are only few of the models you will find in the literature. Rational comprehensive model, which focuses on trying to follow the rational decision-making model. So you step by step go through problem identification, then alternative identification, and so on. While the incremental one refers to the situation where policy changes happen very slowly. Small changes lead to big undertakings within the health system, while the networks or kings and makers model focuses on who has power. So who makes the decision? Here, the kings are those who are at the sharp edge of decision making, policy makers, as we call them usually. While kingmakers these are people, influential people, sitting behind but influencing the policy makers through their power, using, it could be through wealth or expertise or other means of influence. While garbage can refers to the policy process as a chaotic, unsystematic process where the different pieces of stages that we identified happen very randomly in reality. So in policy analysis, it's good to take into account these different models to really understand them. When we refer to policy analysis, we are referring to trying to understand the policy process in two situations. One, after it has been implemented, or second, before even it is being crafted. So it could be in preparation for crafting a policy, or it could be after the implementation of the policy to understand whether it has worked or not. But policy analysis means different things to different people. For an economist, it might be about understanding how to use scarce resources, while for a health planner, it might be about determinants of health and disease. For a doctor, it could be about service delivery, about saving lives, averting deaths, and so on. But in its real meaning, health policy should be viewed as politics, because it deals with not just about the content, it also deals with who makes a decision, who implements those decisions, and how those decisions are implemented or ignored. Not all policy decisions are implemented in reality. So in policy analysis, what we try to do is we want to understand how decisions are made and how those decisions have influenced population health status and how they are implemented or ignored, modified throughout their implementation in the policy-making process. One more framework, which is very useful in understanding policy in policy analysis, is a policy triangle. In this triangle, we actually have 4 angles. So the context, process, content, and actor at the center. By actors, we refer to participants in the policymaking process. This could be individuals, groups, even organizations represented in the process, while content refers to what is in the policy document. Okay, what is the intent of the whole intent of the policy, while process refers to the different stages I just described for you. And context is about the political, social, cultural, historical issues that surround the policy-making process and its implementation in the health system. To give you a little bit of detail about each of the corners within the policy triangle, when we say context, we are referring to political, historical, economic issues, as I mentioned earlier. So contextuality is really very important because of the complex and dynamic nature of the health system. So policies should be really relevant to the context within which they are made and implemented. The factors that we have within the context that policymaking happens could be categorized into 4. Some are situational factors. These are non-permanent factors, temporary factors that really impact how policies are made and implemented. For example, war, disaster, pandemics, or any sudden undertakings within the health system. They are temporary, but have a lot of implication on how health policies are made and they are implemented in health systems. While structural factors are inherent factors of the health system. This refers to how health systems are organized, financed, and operated in reality. And the third factor we have is cultural, religious factors, which clearly has implication. And of course, international and exogenous factors have also appearing, particularly in countries like Ethiopia, where official development aid contributes to a lot in financing health systems. So you usually receive preconditions when you receive funding from an external body, such as the one you see on the cartoon image. Going back to actors, how should we understand them? These are people, individuals, organizations which are made up of people, and even the state, government itself might be one of the actors. So the policy triangle, when it refers to actors, it is a simplification because actors are not separate from the organizations that they represent. And organizations are made up of people. And not everyone in an organization speaks equally. And the values and beliefs of individuals within an organization or within a group really differs. And because of that, identifying actors in the policymaking and their interests and their power interaction is not an easy task, as you can clearly see. So the level of influence of these actors could be at local, national, regional, or international level, depending on who you are, with whom you work, and what your interests are, and what potential to influence you possess in that particular policymaking context. So to understand how much actors influence the policymaking process, we need to understand the concept of power and how it is exerted. To define power, it is your ability to influence others within the policy environment. And we don't have to confuse it with authority, which is your right to make decision in an organization or system. So power might emanate from other things other than your authority. So it can emanate from your wealth. It might emanate from your position in the society. So because of norms, values, traditions, people have different views about their leaders or important figures within their society. And it might also relate to your personality, your charisma. If you are a likable person, people tend to listen to you. So you will be influential. So that's your potential to influence others. So it matters in the policy-making environment. And your potential to influence others might also emanate from your expertise, your level of knowledge, your access to information within an organization or system, and your level of training about a subject. But power might also emanate from a legitimate, organizational or system authority, which gives you, the right to reward or to punish people within the system. But power is also tied to not only to yourself, but also to the organizational structure that you share with. As you can see, this teacher is trying to punish the student for cheating, but the student has come with 15 underpants. So the punishment, although it is according to the rules, might not be effective because of the action of the student. So all actors within the policymaking process try to do their best to really secure their interests. That's why policymaking can be viewed as a struggle between groups with competing interests, some in favor of change, others opposing to the change. So policymaking is often followed by or results in conflicts. The outcome of the conflict depends on two things. One, the balance of power between the actors. Two, the process or the rule established to resolve power. And power could be soft power, which tries to control thoughts by controlling information, and could be hard power, where you punish people when they misbehave, according to your definition, or reward, or give the carrot when people behave as you want them. So in the policy making process, your intent is, as a policy actor, your intent is to get others want what you want. So you tend to do that through persuasion or coercion. So in power analysis, we have three important things to consider. One is relationship and network. How are actors relating to each other? The second one is, what is the source of power for each of the actors? And the third is, how are these potentials from each of the actors exerted on the different actors within the policy-making process? Hence, to conclude, power is the ability to achieve a desired result irrespective of the means. As you can see on this image, sometimes with force, other times, with persuasion. The most important thing in the policy-making process is to really secure your interest, and securing your interest might really result in affecting others within the policy-making process. Yeah, so that's it from me. Professor Samuel will move on to the next session.
Okay, all right. Hi, everyone. Greetings from me. You can see now we are joined by 71 participants. So I will try to build on what Kuzi has already alluded to with respect to policy making. So I'll bring you to the idea and the concept of evidence-informed decision making. So we will be trying to achieve these few objectives. So in our discussion, we'll highlight about the kinds of or types of policies or evidence that are relevant for health policy decisions, and how to appraise or assess for trustworthiness in general about the quality of evidence. And we'll talk briefly about the evidence to decision thinking in terms of connecting evidence to choice, or as Murkuzi has already said, policy is an option or choice. And last, we'll look at a few key strategies in terms of promoting evidence-informed policy making. So before we go into the discussion, I would like you to see this cartoon. Want to give you a break from listening to our talk. I'm sure everyone is able to see a cartoon here, and I'm almost 100% sure that everyone is seeing the same picture or the same cartoon on the slide. And I can also guess there are different understanding of what to see or what will be seen in this cartoon. So what I see is a person behind the camera and looking at the screen. So this is what is visible for everyone. If we had time, we could have gone into discussion of what you're seeing, but because of time constraint, let me add one layer to this cartoon. So we have now more information or more data coming to this picture. And I have also guessed that now we have, some of you have changed your initial impression or initial interpretation of this picture or cartoon. Let's move to the next slide. Look at this. Again, almost 100% of the participants here see the same picture or the same cartoon. Some people might be interpreting this differently. Let's move to this one. Again, some people probably have changed their impression of this picture or their interpretation of this picture. So I will not go into explaining and so on. I'll just use this as a background for my next slides. So I'm sure you'll be able to reflect when I'm describing some concepts. So I would like to start with the definition of evidence. So what's evidence? And in the Mentimeter, I have seen people have defined evidence as data, information, knowledge, and so forth. So that will indicate that we have different impressions and different understanding of what evidence is. There are various definitions, but I would like to take you to the very simplified definition of evidence, which is the available body of facts or information that can come from formal research or statistical analysis or rigorous scientific method, or it can be people's value, context-sensitive experience, and wisdom. I will zoom in more because you have seen from your responses several terminologies. So the issue of clear definition of evidence, data, information is still difficult to get, but I try to summarize these concepts here or these ideas here. So when we talk about data, it is the simplest form of the knowledge spectrum where we get facts which represent the past with high certainty, and they are reductionist and they are more objective. And usually they are parts, small pieces. For example, it could be temperature measurements. It's just fact. Or it could be height or weight, or it could be something else, okay? Or liver size, or it could be distance. So these are simple facts. You put this together and you will produce information. So you put the parts, you connect the parts, and you increase one step up. For example, here you see hemoglobin A1C, which is measured. It's a biochemical measure. You measure it, but you can link it with morbidity. It's another morbidity. You count mortality, the number of individuals who have died of a condition, and you can link the two. So that will form what we call information. And the next hierarchy is use information, the different parts, and create a whole. And what we call knowledge. A very classical definition of knowledge is justified true belief. So we must have the three criteria fulfilled to call it a knowledge. That means it's not necessarily be a true belief, it should be a justified and true belief. So in that sense, we add also some element of belief, some element of personal judgment. That's why we call it a little bit personal, and it becomes less objective. And usually it can define the current as well as also a future condition. And in terms of certainty, the certainty spectrum decreases with knowledge. The next level is wisdom. Wisdom is knowledge plus experience, a very simplified definition. Wisdom and is with experience. So evidence comes in between the two. So evidence is usually a combination of knowledge and wisdom. If we take the example of hemoglobin A1C and morbidity, you know that hemoglobin A1C, higher hemoglobin A1C can lead to increase the risk of mortality in diabetic patients. But if you add the wisdom, okay, in a population living in tropical weather, okay, will this knowledge hold true? Or if you want to design a program based on this, what would you do? What contextual factors would you take? So Merkuze had been mentioning about context. So here, the issue of context becomes prominent, as we see in this slide. So knowledge, evidence is a combination of knowledge and wisdom with a good understanding of the context. So when we come to the decision making, or in terms of using evidence for decision making or policy making, so note here, I'm interchangeably using policy making and decision making, because policy is also about a decision tool, but all decisions do not necessarily need policy. Okay, you can make a clinical decision. So clinical decision for individual patient doesn't need policy, but at the same time, it requires treatment guideline, standard treatment guideline. That's a policy tool. So you can use interchangeably. So here I'm introducing you to broad concepts. One is what we call evidence-based decision making. I'm sure you've heard, those of you who are physicians or clinicians, you have heard this several times about evidence-based medicine. So here, your decision or your practice is heavily influenced by scientific evidence. It doesn't mean it's 100% dependent on scientific evidence, but mostly dependent on scientific evidence. So a good example is on the Mentimeter, you've seen like malaria treatment guideline. So malaria treatment guidelines are designed or developed based on current best knowledge using clinical trials and more rigorous clinical studies. So you cannot really put your opinion in treatment guidelines, or you cannot just put cost as one factor or the main factor for selecting a treatment option, treatment guidelines. So when you come to the evidence-informed decision-making, as you see, there are several elements which will supplement or complement scientific evidence. So scientific evidence becomes just one part of the decision element. So you have other factors like the political environment, resource, community values, and other factors. So we tend in health system and policy, we tend to use evidence-informed decision-making because the mere use of evidence, scientific evidence, is not really practical. So we need to combine other aspects in the decision-making process. So what do we mean by evidence-informed decision-making? So we've quickly looked at what evidence is and what the decision is. So the most common definition for evidence decision-making is it's a process, but a very systematic process and transparent. It should be done in a transparent way so that people can repeat and should be able to get the same result, or should be able to appreciate the way it's done using best available evidence. So here, the key term is best available evidence, meaning the available evidence that you use should fit to the questions at hand and the decision-making process. So again, on the picture, you can see that the best available evidence should be combined in policy making or public decision making should be combined with other elements of the decision making process. And this process involves several actors, and it's a complex process. It's not a simple, straightforward action. But for the sake of understanding, there are distinct components. The problem identification, I think Mkuzi has already briefly mentioned about that. Usually, the process of policymaking starts with problem identification, but not always. It can start with knowledge synthesis or starts from evaluation report. But these are the key elements in the decision-making process and the key actors. These are just examples. And as you see, the process can go from one step to others, but not in unidirectional pathways. For example, the problem identification will come in the next slide. The problem identification might require you to get a lot of evidence before even going to generate evidence for that problem. So this is just to show you that the policymaking or the evidence from decision-making process is a complex and adaptive process. So what type of evidence do we need to make a health policy? So we might require evidence to really articulate, understand the problem at hand. For example, it could be the burden of the problem, the trend of the problem, or what the determinants of the problems are. Or we know the problem, we have defined the problem properly, but we don't know the solution. So we might look for evidence, we might turn our face to evidence to get solution for the identified or prioritized problem. So what works and what doesn't work? We might have we might know that there's a problem clearly. We have the interventions or the solutions, options, but we don't know whether it works and how it works, or whether we can do it or not, or whether it's acceptable or not. So implementation phase also requires us to use evidence. So it could be an economic evaluation, it could be operational research to see people's experience, stakeholders' experience, or see other dimensions like equity. Is everyone benefiting from this intervention equally? Or is it acceptable by everyone, or at least most of the people we are trying to target? Probably one element which probably is missing in this slide is the evaluation component. Again, we pass through all these steps. We know the problem, we know the solution, and we know how to implement it. But after implementation, you need to evaluate whether your policy has made the required or the anticipated or the planned objective or impact. So in that case, you need evaluation of the policy that is created and implemented. So in that case as well, you need evidence. So you do evaluation using evidence. So where do you get evidence? What are the sources of evidence for example, for refining the problem or understanding the problem or to really analyze the problem? So as we said, it might be measuring, we might be interested to measuring the magnitude of the problem or the trend, distribution, or equity. So there are several sources of evidence that you can use. But keep in mind the definition I showed you about data, information, evidence. So some of these lists are here, probably data, but it should be converted into information, knowledge. So you can get data from the routine health system, what we call DHIS2 or HMIS. You can get data from population surveys like the DHS survey or disease surveillance data. You can use these registries. For example, cancer registries can be used to really measure the magnitude of a problem, or burden estimates, modeling. It could be based on modeling, or service coverage and quality indicators. For example, we have what we call the service provision assessment survey, which is done to check the quality of services in a certain region. Or it's just SARA. SARA is service availability readiness assessment. So it tells you about for example, if you want to see the distribution of NICUs or neonatal intensive care units across the regions, where is it heavily available, or what are most of the NICUs are available. You go for this type of coverage gaps identification indicators. So you can really refine or further analyze problems based on this type of data. For identifying the intervention options, most people use systematic reviews, meta-analysis. Usually it's the best starting point. Clinical trials to show you the causal effects and also show to see the effect of a certain intervention in a very highly controlled environment, or observational data studies which shows you real life situations and long-term outcomes. Or you can use also natural experiments, like using difference in differences without really designing intervention, but you go into a certain place where there is already an existing program, use another geographical region or population where the program is not yet implemented, and you can compare the two as natural experiments. So that you can get credible or best available evidence whether a certain policy option or a certain public health intervention works or not, or it has any unwanted or detrimental effect on the health system or population health. The third component, which I showed you previously, is about implementation. So before implementation, you should ask these questions. What should we take to implement? Now you know the problem, you have the options from the various data sources, from the various evidence sources, but you cannot immediately go into implementing it. You need to answer basic questions. Do you have what does it take to implement it here in your context? Okay, an intervention might have shown excellent results, excellent feasibility and fidelity in agrarian settings in Ethiopia, but it doesn't mean this intervention will automatically work if you take it in pastoralist area. Or this study or this intervention might have been proven to be effective in West Africa. You cannot automatically transplant it or copy paste it in South Africa or in East Africa. So you need to really check whether that evidence or that implementation works in your particular setting. So these are the type of studies or the type of evidences that you look for, okay? Particularly the delivery models. What does it take? Should we do it on community level? Do you need digital support and so on? Another important question you should ask before implementation is it worth and is it affordable? So this is the most important question usually policymakers ask you. Often we academicians focus on efficacy or what works or what doesn't work. But when you come to policymakers, they are interested for good reason and for obvious reason whether that intervention is affordable. Okay. For example, an oncologist might do a small study using highly funded pharmaceutically funded research, and will say, okay, drug X works for cancer X, and then we will present the finding to the Ministry of Health, and then the first question they will ask is, how much does it cost? Can people afford? Can the health system afford? So this is an important evidence that you should look for before deciding on implementing any intervention. Is it acceptable? I mean, some treatments or some interventions might be affordable, either government or groups or companies or organizations or societies might sponsor it. But is it acceptable? Are there any barriers when you implement it? Could it be culturally fit? Would people be trusted? Okay, or is there any stigma? Okay, for example, condom use. You might say, okay, condom has been shown to be very effective in preventing sexually transmitted disease, but how is that perceived in certain communities, compared to other ways of preventing sexually transmitted disease, like abstinence? Okay. And there could be also certain adaptations that you might do to preserve effectiveness. So depending on the cultural and other settings, you might need to do adaptation during implementation. So another important aspect when you look at evidence beyond the core purposes, problem identification, identifying intervention and implementation, is the quality, the actual nature of the evidence. That's what we call appraisal. So why do we need to check the quality of evidence? because not all evidence are valuable, or not all evidence have got good quality, whether it's published in Lancet, whether it's done by a prominent researcher, a prominent, very prominent institution. Every evidence should go under scrutiny, what we call like appraisal process. So is it trustworthy? You look at the methodology that has been employed to generate that evidence. For example, if it's a clinical trial, you look at whether bias has been really controlled, confounding had been really controlled, or the methodology, the intervention has been implemented equally across the different arms. Was bias really reported during the publication, or was it reported properly? So you check for all this in terms of checking for the trustworthiness of the evidence. Other might be to good quality, but does it fit to our purpose? As we said, the best available evidence should fit to the problem at hand and should answer your question. If your question is, let's say, which methodology, which digital technology will increase coverage of certain disease treatment, then you should go for an evidence which has worked on that specific question, not on something that has been working on drug. Okay, so the data that you are having at hand should respond to the specific policy questions that you're going to respond to. As I said, again, contextuality should be checked. So I have briefly touched upon about this. So will it work here? So not only the quality, the relevance, but applicability should be also appraised when we talk about the best available evidence. People agree in using evidence, but not everyone uses evidence for decision making and policy making. So there are various reasons why evidence is not properly used or widely used in most policy making scenario situations. So these are some of the reasons. There could be many, but I have picked a few of them. One will be timing mismatch. Policy windows are short. Because it has alluded to what we call this the stream concept. You have the problem, you have the intervention, the solution, but you need the context, the window of opportunity. So windows of opportunity usually last very short, while research and other evidence generation endeavors and processes take a lot of time. So there could be a big time gap in terms of availing the evidence timely for decision makers. Okay, so that's probably one of the reasons. Other could be there might be a lot of data out there, but with a lot of conflicting findings. So for policymakers, really it will be difficult to choose from. Okay, so that could be one reason. The other could be limited capacity to identify the best available evidence. Either you have one or two or three or more than that evidence, but you need the skill to really pick the right information for the right purpose. So that might lead also to trust. Who is doing this? If you don't have the capacity to analyze it, you just depend on the person. Okay, if I trust someone, I will take that one. But that's not a very scientific way of identifying the best available evidence. There could be also competing interest because of political pressure, people's opinion, lobbyists, and so on. So policymakers tend to use or to avoid evidence in favor of pressure from the community. Okay, not only time pressure, but also from community interest or funders' interest, or as we have seen, power is an important element in policy-making process. So those who have got the power might push the policymakers away from using best available evidence, even though the policymaker wants to use the evidence, but the situation may not allow him or her to use that. Sometimes evidence are not usually localized. They don't represent the local situation. So you end up getting evidence from other places and you don't have the right information, even though that study is high caliber, but it is done in a different area. Others are like a lack of appetite of policymakers, and then so many factors are there. But how do we avoid this? How do we mitigate these things? I think there are certain strategies where you can use that can be used to increase the use of evidence by policymakers or decision makers. But what I would like to mention at this point is when we talk about policymakers, usually what comes to our mind is either the prime minister or the health minister or the leaders in the health system, like regional health bureaus and so on. But in reality, everyone who is making decision is a policymaker. Like an individual doctor treating individual patients is a decision maker, is a policymaker. So keep that in mind. So when we refer to these challenges, we're not really externalizing only to the health system managers or leaders. So we should really look inside and also consider our practices. So one important issue to be considered is, having the skill to answer questions, doing critical appraisals, rapid critical appraisals. And in a system, you can have multidisciplinary team where you can help you. Of course, they should be given clear guidance to avoid conflict of interest. For example, in the Ministry of Health, where we are working with, I and Murkuzi are working, we have established, and in the last 10 years, we have been working with the Research Advisory Council. So this Research Advisory Council brings experts from academia, partners, and other organizations to support the decision makers at the Ministry of Health. So the Ministry of Health spokes or programmers will come up with a certain policy challenge or policy question and forward it to this team, and the team takes up that and then does performs evidence search, evidence synthesis, and provides the policymakers with policy options for implementation. So this could be one way of increasing the interaction between policymakers and programmers, also increasing the trust and then increasing the relationship between the two. And using standard tools, nowadays we have several tools, to formulate research questions, synthesize evidence, appraise evidence, and then also design implementation strategies and so on. So you can use this standard method so that you can avoid all these challenges. You can also, put monitoring evaluation as a learning process. Usually policies are made, but there is little effort or intention to evaluate them at the end of the day and put it as a feedback to improve that's already implemented policies. So I think we need to work on that. Others are creating a good relationship between policymakers and researchers and foster what we call the co-production. So co-production starts from identifying the issues. So it's important to engage policymakers or be involved with the policymakers in identifying policy issues. Otherwise, it will be too late, or it will be minimally effective if you go to the policymaker after you have done your research and taken 3-4 years, and then come to the policymakers and at the end of your research. So that is shown to be less effective. So it's important to engage policymakers from the outset, and if possible, throughout the process, from identification to implementation, evaluation. So in that way, not only the relation, but also the skill also would be enriched. So academicians will learn from practitioners will learn from policymakers. And then you use also, as I said, other tools like policy briefs for major policy decisions. So when we talk about communicating evidence, which is a very important part of evidence-informed decision making, we usually make all the obvious mistake. As you see in this cartoon, you can see the frustration on the face of the person sitting on the chair or behind the table. He's probably the policymaker. You can see he's frustrated, he's annoyed to see 3 volumes of research output being delivered by the researcher for use by him. So he's asking this famous researcher probably to ask, to come back with a few bullet points summarized in PowerPoints. So, the moral of this story is, even if we are well-versed in doing research and we are experienced senior researchers, it doesn't mean we are able to communicate our research findings to policymakers, which is an important step. So what works? How should we communicate? First, focus on the problem, okay? What is the expectation? What is the purpose of this research? What does it answer? And then if you have the answer, put the answers in a very concrete and summarized message. Just leave the jargon, or you can put it in annex. You don't have to send 10 pages of your result to a policymaker. They don't have the time, they don't have the interest or probably the skill to interpret your complex findings. So summarize it and probably put it in a plain language, avoiding methodological jargons. Researchers like writing about complex statistical methodology like logistic regression, whatnot, logits, polylogits, and so on. But these are important, but they are not relevant for the policymakers. So we need to use a plain language and tell them what really works. Not put big confidence intervals, probabilities, and so on. They need to know what works, okay, and what doesn't work. That's the most important message. And then give them options, okay? Give them options based on your evidence, based on the synthesis of evidence we have got. Give them options to choose from. So I think these are some of the elements and the tips for you to have good communication materials. So one good communication material, it's becoming more popular is briefs. We call them briefs or evidence briefs or policy briefs. And I'm just showing you here the components, the key components that should put when you are writing policy brief or evidence brief or communication. Highlights the problem, gives the options, show the benefits and the harms, and most importantly, shows them how much it costs and whether it's affordable or not, how it works and who is it benefiting, would it be leading to inequity or covers equity, what are the models of implementation, and where should it be done, and what are the indicators for monitoring the outcomes, and then what are the limitations. All evidence have got their own limitations. So show them what are the strengths and the limitations. So you should really put all these elements in 1 or 2 pages. This is the most difficult part to do, but this is something that you should be able to do. Other ways of communicating is you can use visuals. These are very powerful tools and important to communicate your findings. You can summarize your findings in tables or matrix forms where you can show the effectiveness, cost, visibility, equity in one table. Show them, how uncertain or certain your findings are and how it works. What is required, what should be done, and what the outcome is. And then what is the budget implication? And, what are the sources of the cost? What drives the cost of this intervention? You can also prepare dialogue and stakeholder engagement. So dialogues should be done selectively. You don't have to do dialogue for every evidence that you produce. So dialogues are different from debates. In dialogues, people have got different opinions in solving a solution. But they may have different opinions, but not necessarily contradicting each other, or one trying to convince the other, or one showing his or her solution to be better than the other. So the whole point is we have one common problem, but we have several options to solve it. So we come to a table with our evidences and discuss, our views, our perspectives, and convince the other part how you did it and what's the benefit and the limits. And then you should be ready to listen. So in a dialogue, the most important part is listening to what the other party is saying. Usually people, discuss, or we say, well, we are discussing, but we are really talking to ourselves. So, dialogue is not speaking out loud or, talking only to yourself. So you should really see people's values and see any trade-offs that you can do in the discussion. And then you need to have a common plan in this stakeholder engagement. So I think we should conclude with these few points. We've tried to see what evidence is, and we saw that it ranges from data to wisdom, but the most important concept in terms of evidence is it is a collection of facts or information synthesized to answer a specific question or a specific policy issue. And there are different sources and types of evidence that can be used for problem identification, designing intervention, implementation, or evaluation of intervention. And this process has multiple aspects. It's a complex process involving multiple actors and time-taking. So when you use evidence, use the best available evidence. Best available evidence doesn't mean RCT or one over the other. Best available evidence means something that fits to your purpose, answers your question, and helps you in the decision-making process. And lastly, we've looked at the importance of, communicating your evidence to policymakers, which is an important element. So with this, I will conclude my session, and we will be moving to the last part of this webinar. And we have case studies. One case study. I hope some of you have already have access to this case study and have come ready or have already read it. Otherwise, we will display it here, and we'll give you a few minutes to read. And that will be followed by a Mentimeter where you'll be responding to these questions, right?
Yeah.
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 So I'll hand over the session to Merkuze. Thank you.
Yeah, thank you, Samir. So you will have the 15 minutes to read the case study. So 1-5 for those of you who have not read it. So I am assuming that Tigist has already shared this on the chat box or somewhere for you to be able to read it. This is very short. So as you can see, not more than a page. So read it through, then we will project the questions and we will conclude our session by answering the questions and then finally by the post assessment that Tigist will be sharing. And in the meantime, yes, so yeah, so the Tigist will compile the questions and we will have time to reflect on those questions and suggestions. And you can also access the case study on the chat box. You can download it, read it through if you have not read it yet. So in 15 minutes, we will go back to our discussion. We have 4 questions to address using our Mentimeter exercise.
Professor Merkuze, if they prefer to access the document on their own, I have also shared it on the chat. It's pinned. The document's pinned, so you can all access it.
Yeah, I have seen it in the chat box, so you can download it. Thank you, Tigist. we will stop sharing and we will project the questions for us to do our discussion in a couple of minutes. Okay. So this is the first question. For those of you who have joined us late, this is how you do your participation. You can scan the QR code or go to mentimeter.com and enter the code that you see. Or Dr. Tigist has already pasted the link. You can go and join from the link, directly from the link. Probably you can pin the link, Dr. Tigist. So identify and list the actors. Who did you see? Okay. People have already started participation. I think this one means international organization. So this means the union. Okay. Yes. Thank you. Any other actor? Any other actor? The union is one of them. Okay, the union. Politicians. Can you be more specific? Who are the politicians? WHO, yes. Academicians, Carl Stabilo, okay. Okay. Any other? TB community, yes. TB community, the World Bank, that's true. Any other NGOs? Let's be more specific. Global Fund to fight AIDS, that's right. People with vested interest. Global Fund, okay, Global Fund. Physician, yes, public health physician, particularly Carlos Pablo, was leading the research undertaking. Technical experts. Stop TB as a program, okay, Global Fund. Media, excellent. Excellent insight. UNICEF, was it UNICEF or a person who was previously working in UNICEF? It's Arata Kochi, right? Arata Kochi, if you have seen it, he was a person who had been working in UNICEF but brought into the World Health Organization to establish or to expand the TB, the tuberculosis activity at the World Health Organization. Any other individual researchers? Yeah, the WHO General Director, Mahler has been identified by a few of you, which is true. He had personal interest in the Health for All initiative of WHO back then. Okay. Thank you so much. So we have, as you can see, a number of actors in this whole process. And all of the actors you have identified have different interests, as you have seen. And depending on their interests, they have been trying to really influence the policy-making process. So let's move on to the next question. But we have 22 response out of 63 participants who have joined the Mentimeter. Should we wait a little bit before we move on to the second question? Thank you. So let's move on to the second one. What sort of power did you see in play? Economic, political, symbolic, expert or knowledge related power interaction? Economic? Yes. Yes. Why? Maybe if people had the opportunity to explain, they would say TB became an agenda in at WHO after its emergence in the economically well-to-do countries in the industrialized world because of the its co-occurrence with HIV. So it started killing people in the West. That's why it became an issue. Yes, knowledge, Aratakochi, as you have seen, although Aratakochi and the union had the evidence that the interventions I developed, DOTS is working, is something that works in low and middle income countries setting. Nobody really listened to them. Why? Because they had the expertise, they had the evidence, but as we discussed earlier, the context, particularly the power relationship among the actors, didn't really allow for action in the early days. But as time went on, there was progress towards acting on TB, making tuberculosis a global agenda, expanding the unit at the WHO, even labeling TB as a global emergency, as you might remember from the case study. Yes. Economic, symbolic. Yeah. So in terms of the interaction among the actors, as we have seen in the early days, it was neglected because it was not a concern to those who can pay, or those who can, invest in programs such as the one proposed by Karl Stablo and the union. But when the problem was felt among those who can pay, it really became an issue. And as we have seen, there was a media campaign, and the media campaign followed the expansion at the WHO and the labeling by the World Bank as a program where investment is cost effective. So TB, investing in TB was cost effective according to the World Bank after it started to appear in the industrialized world. So you can see that, it's not only the presence of a problem together with a solution that results in action. It's rather the presence of the problem, the solution, and at the same time, the enabling environment, then the context. And that context might be affected by the political environment, by the availability of evidence, by the economic arrangements that follow, and so on. So, we have to understand that policies are not only influenced by evidence, but also by other factors, factors other than evidence, factors other than the burden of the problem, factors other than, the quality of the intervention or the solution that has been proposed, and so on. So there are other variables which play a part in really making policies to be. Samuel has.
I think, thank you, Murtaza, and thank you everyone for responding to this. I think this is a good point for reflecting on the two types of school of thought I told you about: evidence-based policy making and evidence-informed decision making. So this is a clear example of evidence-informed decision making, where other elements are playing major role. Because even though the knowledge has been there, the evidence has been there for quite some time, it has not been translated into policy, given the contextual circumstances that Murtaza described. So just to emphasize that.
Thank you, Samuel. Yes, so let's move on to the other important question we have for this case study. What structural and situational factors hindered or facilitated? You can write hindered, then the answer. Facilitated, then the answer that you have. So, or you can choose to just drop the answer, and we will classify that according to how it was framed within the case study. So, for example, what important structural issue did you see in terms of affecting whether action is taken, whether TB was given? Okay, facilitate the fact that TB resurged with HIV, linked with HIV in high-income countries. Excellent. Yes, very important facilitator for reappearance of TB as a global agenda. Another facilitator was the advocacy, which was done through media. That's true. But this followed the previous factors that we just mentioned. Political issues, I think this refers to the relationship among the actors. WHO, expansion of WHO in response to appearance of TB together with HIV in high-income countries. Factors that hindered lack of adequate financial resources. Yes, although Carl Stablo and the union had all the evidences that it worked, if you read through the article on which this case study was based, you will understand that several RCTs were concluded in low-income countries, proving that intervention really works in those settings. But it didn't really go through because of resources. Another hindering factor, health for all focus. Yes, it was preoccupation of WHO and its general director by the Health for All initiative. That is true. Another hindrance, public health community disagreed about best practice. That is true. Oversimplification, yes, the TB community believed that this is oversimplification, and it's against investing in research in TB and so on. That's why they said they really opposed to the introduction. And in the 1970s, the international policy system didn't support the vertical approach. Yes, this is the health for all approach and the vertical approach in health policy. Samuel wants to chime in.
Let me come in. At one point you raised is about the conflict between the scientific community, within the scientific community, where one group wants to have more advanced research, undermining the benefit of this evidence, which is the DOTS intervention. So resistance shouldn't necessarily come from programmers. scientists can have also resistance in terms of using evidence. So I think it's important to engage everyone in the decision-making process. Otherwise, you'll have a lot of pressures, particularly when it comes to implementation. It's typical, like senior physicians who are used to work in high teaching hospitals may see some interventions developed at primary committee levels be very, very simplistic and unrealistic.
Yeah.
One example, for example, the treatment of sepsis. Sepsis in our national guideline, we know that as the gold standard and the best place to treat neonatal sepsis is in NICUs or neonatal units where there are highly skilled professionals. But that's not feasible in all circumstances. So our national guideline gives an option to treat sepsis at health post level with injectable gentamicin and oral amoxicillin. I don't know how many of you know this. So if a neonatologist hears for the first time about this evidence, he or she automatically will be resistant. How can you treat sepsis with oral antibiotics? If you involve them in this discussion, why this is happening, why it's important to consider for equity. It's about now equity. It's not about the scientific procedure, but it's also equity. Accessing or reaching those who are vulnerable, who are likely to die within the community before reaching the health facility or without reaching the health facility. So this is an important point that somebody raised this point. So I just wanted to zoom in on that. Thank you.
Thank you. Thank you so much. So let's move on to the last question about evidence. How do you rate the influence of evidence in the policy-making process on a scale of 0 to 5? This is a sort of survey to really understand your grading or rating of use of evidence in that particular case.
So this is about this case.
Yeah, this is about the case study, by the way. So did really evidence make a difference, So look at what happened during the early days in the 1970s and later on when consensus was obtained, not just one of the stages. Yeah, so we have reached to a level of 3.6, an average of 3.6 by 14 participants.
Let's get more responses,
yeah,
so that we'll have a more realistic survey of your opinion.
Yeah, good.
So, by the way, we are generating evidence here as well about your responses, your opinion. So,
yeah,
you can conclude later. Yeah.
Yeah. As you have seen in the case study, in the early days, the evidence didn't really matter. But, as time goes and as the window of opportunity came into light, people, a group of experts, as you have read, went and visited the union in Arata Kochi, listening to them about how their intervention worked and so on. So, when the window of opportunity occurs, evidence is more influential as opposed to, when there are competing factors hindering its use, its application in decision making. And I understand some of you had some reservation about it. That's why it's only 3.3 that we see for 21 respondents. Because some felt, close to none, while others felt strongly. So it's like a middle ground that you have given us. But you can clearly understand that from the case study, it really takes a lot of effort to influence the policy-making process using evidence, however strong the evidence might be.
Maybe we can quickly look at the clinical case, where this might be a bit complicated for a clinician. But let's say you have a patient with HIV and TB, you have separate guideline on how to treat HIV, because if somebody has HIV, you have the heart, or if you have TB, you treat TB straightforward. But if these two conditions come together, I think, do you treat together? Do you prioritize TB and then follow it with the ART, or you first give ART so that you boost the immunity and then come back to TB? So this is a context which determines your decision. Even though both have got strong clinical evidence background, they have to make this decision based on the context, the age, and the severity of the disease. Everything should be combined into the equation.
Yeah.
Or if, for example, if this person is coming from a far place where you cannot just evaluate him frequently and see you can make a decision. He says, I live far away from this, and then I have to get both together. You have to make that decision in this difficult situation. So I think as a decision maker, you can encounter this challenge, whether you have to use real scientific evidence or the contextual evidence in a given circumstance, even for a clinical decision.
Yeah, thank you so much, Samuel. Thank you for your participation. I think Dr. Tegest have pulled some questions for us from the poll, so let's use the rest of the minutes to respond on those.
Thank you, Professor Samuel and Professor Merkuze. You can see the screen, right? So,
Not yet, not yet.
oh, it's sharing. Okay.
Are you displaying something, or?
Yes, I'm displaying the question that I have collected from the participants.
Yes, yes, we can see.
Oh, thank you. So we have around 12 questions. Most of them are actually relatable, so you can answer them briefly. So we can start from the first one. So the first question is there a hierarchy among these? I believe it's based on one of the displayed slides. For example, does law override guidelines, or are they all equally policy?
Yeah, so what makes a policy is the presence of an objective to be attained and the framework or the strategies or the actions outlined to reach that particular objective. So in terms of definition, all of them are equally policy, but their nature and how they are executed really depends on the context. So some are like mandatory to follow through, while others are, given for individual discretion. So yeah, thank you. That's it.
Okay, the second question is, which policy frameworks are better in analyzing policy in the context of Ethiopia or East Africa?
Yeah, so this is a common question in our discussion about policymaking, but we didn't mean to really compare the models or the frameworks. Particularly the policy triangle is really used by many researchers to research or analyze policies in low and middle income settings. But all of the policies, the policy models I have discussed are helpful at some point, depending on the type of policies that you analyze. So it's not like, they differ by their focus and by the way they look at the policymaking process. Otherwise, we don't have to really choose. Rather, use whichever is helpful throughout the policy analysis process.
Thank you. The third question, in Ethiopian context, there is a gap in policymaker and the real practice in healthcare, meaning that the policymaker does not know the real practice and those who knows the real practice do not know about policymaking. What do you suggest, or what is the solution in our context?
Yeah, this is the reality, not just in Ethiopia, but also in other settings too. So the solution to this is working closely with each other, be it you are a researcher, a practitioner, a clinician, or a policymaker. We are there for the same goal. It is to improve population health status. So for that end, it's essential that we work together, starting from problem identification to implementation and evaluation. So the solution is to really collaborate, work together, and create platforms for that purpose.
Just to that, I think a good question. I think the problem is a systematic issue, and it has several layers from individual to organizational level. So as I tried to indicate, everyone should consider himself or herself in place as a decision maker. So it starts from that reflection. And then of course it should go higher up to the organizational level. So we need the structure, we need the capacity, and then we need the culture of using it, So when situations allow, people may not be interested to use, or when they are interested, the structure may not be available. So I think a combination of factors are playing here. But the whole point is, it's not something that can be fixed just by doing something, because there are several layers and aspects to it. Just to give you an example, now we've been working in this space for almost 10 years, and there are certain promising progress, but still there is a lot to remain. For example, one of the big successes we have seen is now the Ministry of Health and regions are becoming more savvy in terms of and more interested in turning their face to evidence before making a decision. I'm not saying that it's perfect, but there is a significant but small but significant change over the years. And some of the institutions have already established certain structures. For example, the structure I mentioned about the Research Advisory Council had been operating under the Ministry of Health within maternal and child health for almost 10 years and has shown remarkable change. Another development probably you should know is the Policy, Strategy and Research Lead Executive Office, which is one of the highest offices within the ministry, which is directly accountable to the minister's office. So their overall aim is coordinating this evidence-informed decision-making process across their system. So that is giving oversight, putting roadmap and then coordinating all these activities across the different stakeholders, across the whole levels. Thank you.
Thank you. The next question is, if scientific evidence is just one of several factors in evidence-informed decision-making, how do we ensure it doesn't get sidelined by political judgment or organizational constraints?
Yeah, this is also a very important question, and it's a real-life question. So again, there is no specific one shot to this answer, one answer to this question. So you need to have the structure, as I said, but in my view, one of the most important part is creating the trust and working relationship between the policymakers and those who are generating evidence. The how part could take several pathways, but that's the most important principle. So if policymakers know where to turn to when they're looking for evidence, or when evidence generators know to whom to talk to when sending their evidence, that's an important component. And having good relationship and trust. When we say trust and relationship, it doesn't mean that giving away for values or giving away your integrity. So sometimes you might be asked to subscribe to something that you don't really believe or you don't have strong evidence. So it doesn't mean you have to compromise the scientific integrity when you are working with policymakers, or the other way around. Policymakers should not really should be able to really say and come forward and ask, okay, this doesn't make sense. Your evidence doesn't make sense. Go back and check your results. So you should be able to be open, to critics from policymakers, and policymakers should be also open to critics or feedback from the scientific community.
Okay, thank you. So in your experience, when community values and scientific evidence conflict, how should policymakers navigate that tension?
Important. I think one solution, not solution, but one approach is to engage the community from the outset. As I said, this co-creation, the concept of co-creation, one of the benefit is, avoiding conflicting views at the early stages of the policy-making process. Instead of waiting until the policy is already made and the guidelines are distributed, and then you see communities going against it. So if you involve the right community actors before the policy is developed or during the policy-making process, you can identify those conflicting views and come to a consensus. For example, the dialogue I mentioned community may have a different view of solving a solution, or the policymakers have a different one. The scientific view has may be different. So that you need when you need proper dialogue, bringing all the key stakeholders in this policy making process. Thank you.
Thank you. Which organizations in Ethiopia are tasked with knowledge to policy translation?
Yeah, this was touched upon by Tsunuel earlier. We have the Policy Strategy and Research Office at the Ministry of Health, which is directly accountable to the Minister herself. And we have also, the different knowledge translation units in research institutions that are under the leadership of the Ministry of Health. But it is a good starting point to really talk to that department, the Policy Strategy and Research Office, to receive guidance on how to reach the relevant program within the ministry. In regional health bureaus, if you want, you can talk to the research unit, which sits under the Public Health Emergency Management Directorate.
One quick note as well is, again, we're talking about one side, the user, but producers are also responsible in engaging in the knowledge translation. Not only, the traditional view is, universities are only there to produce research evidence, not really contribute to translation. But now the new paradigm is universities should be engaged from the initial concept to the translation process. Even though their contribution, the magnitude of contribution varies, they should have their role from the outset. So universities should have this inbuilt structure within their organization, or research institutes for that matter. Yeah. Thank you.
Thank you. Are Ethiopian health policies developed based on the best local available national data? Are they transparently and rationally developed and implemented? If you have evidences, please share us your experiences, particularly on our research outputs and policies.
I think we don't have a single answer to this question, because there are several policies, and the extent of evidence use in different policies really differs depending on who is engaged, who leads the policy-making process, and so on. But these days, as Noel mentioned earlier, we see, improvement in policymakers' intention to use evidence in decision-making, and researchers are becoming more intentional in promoting use of evidence, engaging policymakers from the very beginning to the end throughout the research cycle. So we don't have really one answer to this question, but it is improving over time. And because of that realization, even the structure we just mentioned was created at the ministry.
Thank you. I'm going to read these two questions together because they're relatable. How evidence-based are healthcare policies and law in middle-income countries, especially in regard to local relevance? Evidence shows that policies might actually be driven by donor priorities in such settings. I know lobbying or interest group influence on policy is significant in the West, especially in the US. How relevant are interest groups in health policy priorities, I think, in Ethiopia?
Yeah, so in terms of the influence of donation of child development aid in low-income countries, it is very significant. Even they determine the terms and the approach in policies. Why? Because they pay, so that who pays the piper calls the tune. So that's what happens in terms of international or external influence. In terms of the role of interest groups, it's really, I would say it's a spectrum. Depending on the nature of the policy issues that we talk about, interest groups engage, professional associations, patient groups, even other community-based organizations, join the policy debate when they find the opportunity. So it really depends on what policy issue we are referring to and how, to what extent the policy environment is open for participation. So it really depends.
Yeah, just to add to that, I don't think we have a very pragmatic or empirical evidence to answer these questions objectively, but I can argue that, it's a very at a nascent stage, especially the influence of lobbyists or interest groups trying to influence health policy. Probably one of the reasons could be, it's a reflection of the overall political and economic structure and culture of the society, where we are very much used to being a recipient and not really being proactively involved in any public decision making and policy making. So that reflects also how our society has come through over the last so many centuries in deciding our own way of living. So I think I would say it's a very, very early stage, but it's coming in certain ways or in certain spaces. There are some interest groups, especially the young ones, with the influence of, the social media and other digital media. People are trying to influence, but it's not structured, it's not systematic, it's not organized. People are trying in a very random fashion, but that needs to be organized going forward and make a very real impact. Over to you.
Thank you. Okay, I think that this question has been answered, but you can
Yeah.
reflect on it
Yeah.
or have an opinion. This one, people with lived experiences should be part of the policy making and evaluation process. For example, people living with mental illness.
Yeah, I think we have addressed this too. In a way, yes, there should be the opportunity for people with lived experience to join the policy debate. But as I said earlier, it really depends on the nature and type of the policy issue we are referring to. And we have reflected, it depends on several factors in terms of participation.
Thank you. The other question here, how do we find balance between assuring quality research works as an input to evidence versus promoting evidence-based or informed decision-making in the continent at large, considering, this is me, by the way, so especially considering the fact that there is a huge publication bias in our country because most of the papers don't get published, and those that are published has like a majority of them, they have an issue of quality. So how do we balance that moving forward?
Yeah, that's a big and important question. I think for me, in principle, there should not be any compromise regarding the quality of research, whether it's done in the south or the west or whatever direction you mentioned. It really boils down to the quality, the actual quality, and the way it's measured. So I know there is a tendency for obvious reason to rely on publications or evidence coming from the economically advanced countries, but it's not always true. So it all depends on the actual quality of the evidence. People are talking about, decolonizing science and so on, but that shouldn't really compromise quality. We should not really go for local evidence just because it's locally produced without really looking at the quality. So wherever it's produced, what's important is the quality of evidence. Thank you.
Thank you.
Okay, I think the rest are like more of a suggestion than maybe this one. Maybe this one, yeah. From your personal experiences, what's the weight of lack window of opportunity in resulting in action? How resilient should an academician be given this scenario?
Yeah. So it's not only for the academician or the researcher to really wait for the window of opportunity. Sometimes it is also for, change agents in the political environment, change agents in societies, not just, so action in the policy making process, as you said, it has some component of luck, but it's usually like a result of constellation of factors that creates the window for action or the window of opportunity. So I would say it's not only the academicians that's waiting for the opportunity. It's all actors who are really concerned about the issue. So it's a common effort, and sometimes the window of opportunity might be created intentionally. Other times it just appears by luck. So yeah, it's not just for the scientists.
Yeah, a quick reflection is, interesting question. I think one aspect of this process is the academician or the researcher who is interested to get his or her evidence into action should really be committed, should be really smart and find the right ways. As I said, for example, how should he or she is communicating or should communicate this evidence? It could be the best evidence, but the way it's communicated, it may not be to the right person. So it should be to the right person at the right in the right format for the right place and the right content. So yes, it needs resilience and commitment, but also you should be also smart, not really push against the wall. Go find the best way to do it.
Yeah.
But it's not an easy work to be sure.
Yeah, not easy for any of the actors within the policy environment. Thank you, TG. Over to you.
Thank you very much. So I don't see any additional question. I believe this is it from the audience. If you have anything to add, Professor Samuel, Professor Merkuze, you can conclude.
I think we have said it all. Anything to add?
No.
Yeah,
I think
yeah.
thank you for your time. I think we're available if you want further discussion or information. You can take our address from Dr. Tigist or approach us individually, so we can be of help if we can in any circumstances. Thank you.
Thank you very much, both. It was honestly one of the sessions that I enjoyed very well. We're like in 2 hours and 16 minutes now, but it doesn't feel like that. It was very informative, interactive, and it's more like an in-person session than a virtual session. Everybody was interested and interacted very well. It's really a big honor to have you here. Thank you very much. If there are additional questions, the audience can forward them on the chat box, and I'll collect it and forward to to our speakers, so we can reach out to you through all platforms. I think while we're here, I'd like to announce that Fenot Associates will also be collaborating with us for the 10th Ethio Health Exhibition and Congress in organizing a panel discussion, a high-level panel discussion on healthcare financing, which you don't want to miss. It's an in-person session. It's going to be the coming Friday morning at 9 a.m. at Addis International Convention Center. The post and formal call will be posted later today or early tomorrow. So we'd really love to have you there and continue the discussion on healthcare financing and also evidence-informed decision-making. Thank you very much. I think with this, I will conclude the webinar for today. Thank you.